Well, thank you, Louise. As you know, we're going to hold the questions for the end. And coming up next, we have Dr. Aurélia Poujois, who is reputed professional in neurological involvement connected with Wilson's, and she works at the National Reference Center for Wilson's disease and other copper-related rare diseases in Paris. Thank you so much for being here. You now have the floor.
Hola. Buenos días.
Good morning. I would like to thank the organizers of this meeting on Wilson's, and I'm delighted to be here with all of you to discuss the neurologic involvement of this disease. Sorry, I have an issue with my mic. I will not continue in Spanish because it's pretty shaky. So I'll change to English, which is not my mother tongue either. So I hope that my English be understandable for the interpreters who are so kind to listen to me and try to translate what I say.
So I'm a neurologist. Do you hear me? It's okay? Yeah, great. So I'm going to talk about the brain in Wilson disease. And just before starting, I'd like to just emphasize the importance of guidelines. So the first talk was a very nice summary of the guidelines. And we have international guidelines, European guidelines, and very recent guidelines. And for us, physicians, it's very important to have the guidelines because it allows us to talk all together. So I'm a neurologist, so with this guideline, I talk a lot, I communicate a lot with my friends, hepatologists, pediatricians, biologists, geneticists, and so on. So it's very important in this disease to communicate between physicians and, of course, with patients. So these guidelines are so important, and we are lucky because we have very updated guidelines in 2025. So you all know, in few words, Wilson's disease. It's a rare genetic disease. For example, in France, we have around 1,500 patients with this disease. I've heard that in Spain, it's maybe around 800 diagnosed patients. So it's a rare disease. And you all know that it's a genetic disease that is caused by the mutation in the ATP7B gene, and which disrupt the copper balance, and the result is the copper accumulation in your body. And this copper goes first in the liver, then go outside the liver if you are not diagnosed and if you have no treatment for that. So that's the reason why the main symptoms are hepatic, but if the copper continue to go in your body, you will have another symptoms outside the liver, which be neurological symptoms, psychiatric symptoms, or ophthalmological symptoms. Apart that very main symptoms, that this we also we have described also another symptoms. So we know that the heart can be involved slightly with, but it's present. You can have bone problems. That's the reason why you need to take vitamin D during the year. I know that in Spain you have a lot of sun, so maybe you don't take vitamin D a lot. But for example, in France, we have less sun, so we need to take vitamin D to protect the bone. And for Wilson's disease patients, it's extremely important to take vitamin D to protect the bone. The kidney can be involved as well, and for the woman, gynecological symptoms can appear. And for example, it's very frequent to have miscarriage in women that are not diagnosed or not treated. And when you the patient are treated, they can have babies and so on. So just to tell you that it's a liver disease, of course. It can be a brain disease, but unfortunately, it can be a systemic disease with a lot of different organs involvement. I like these pictures from our colleague that it's a summary of the natural history of the disease. So the symptoms depends of the copper overload. And at the beginning, if the copper overload is not high, you are asymptomatic. It's only a genetic disease and the copper is slow. So no symptoms. So it's the first petals. Then when the copper goes up, it goes to the liver. So you have liver disease. And then if the copper overflow go over the liver, you may have neuropsychiatric disease. And the very interesting thing is that some patients never become symptomatic. We don't know exactly why. Maybe they have different mutations. But, you know, the last never symptomatic, we don't know. Some patients have the mutation, but no symptoms. Just to finish on a few words on Wilson's disease, we know how to diagnose the Wilson's disease. So we have all the tests to confirm. Of course, copper studies are the key, but we know how to diagnose. The problem is to think of this diagnosis. And as a physician, we have to communicate on this disease, to communicate to liver specialists, to brain specialists, and so on, to tell them when to think of Wilson's disease, because we know how to diagnose it easily when we want to. And of course, treatment is lifelong. We have a lot of treatment. You've heard of that, you know, of course, that with the copper chelators of the zinc. So why thinking of the brain? Just the main reason is copper is very important for the brain. Copper is important for the development of the brain, and copper is important for the functioning of the brain. So if the brain is overloaded by the copper, the brain will not have a good functioning. In France, we have the chance to have a national registry. And so we collected the data from the French patient over 20 years, more than 20 years. And we have around 800 patients in the registry. So from this data, from this very precious data, because they are rare data, we can have a lot of insight about the disease. So we know that 32% of the patients started their disease by the brain, by neurological symptoms. Half of the patients started by liver disease, and around 19% are diagnosed by the familial screening. So neurological presentation is the second most frequent initial presentation, as you can see here. So from the registry, we can see that the mean age at diagnosis for the neurological presentation is around 20 years old. And the main delay from the first symptoms to the diagnosis is quite long. It takes 1 year to make the diagnosis and to think of the diagnosis, to confirm the diagnosis when the patient enters the disease by the brain. So it's very long. So as physicians, we have to work on that to reduce this delay. And my colleague just talked about it previously, but psychiatric symptoms are quite frequent in patients. Around 30 to 65% of patients report psychiatric symptoms. I will talk about it. Just this diagram is to show you, so the red chart is the age of the beginning of the disease. So you can see that it's around the second decade for the neurological form. And for the hepatic form, it's the patient are youngest. It's more around 15 years old. So the neurological symptoms just appear progressively upon weeks and even months. And the symptoms can be combined, and I will detail you what kind of symptoms you can have. Tremor is very, very frequent initially at the diagnosis, as well as dysarthria, which is the difficulty to speak normally, to articulate. And I see that you will have a talk on speech disorders in Wilson's disease. That's very nice. And writing difficulty are frequent as well, 30%. Dystonia, gait disorders are the main symptoms that we can find initially at the diagnosis. So I will show you some examples, and I really thank the patient that they agreed to share their videos with you. So tremor is very frequent. 50% of the patients may start their disease by a tremor. It's an involuntary shaking or trembling of body. So it could be the hands, the head, the voice, the limbs. All part of the body can have a tremor. So this patient have a very, very extensive tremor of the head, of the upper limb, of the lower limb, and also of the voice. The another very frequent symptoms is Parkinsonism. Parkinsonism in this young boy is stiffness, slowness of movement, anemia, and you can look also that he has a dystonia of the mouth. We call it rhesus sardonicus. So the movement is very slow and a bit impaired. So in this young boy, it started 1 month before. Apart from tremor, Parkinsonism, you may have also dystonia, which is a condition that causes muscle stiffness. The muscle contract uncontrollably, so it leads to twisting movement and abnormal position of different part of the movement. So dystonia could be on the face, like here, but it can be also in the neck with different cervical dystonia. And it also can touch the tongue on the right side. So you can see that this patient have movement, a repressive movement of the tongue continuously. So it impairs speech, of course, and deglutition. Dystonia can affect the limbs, like here on the left side. So you can see that the contraction of the muscle in the feet impair the gait. It can be unilateral or it can affect the two limbs. Another kind of dystonia, abnormal movement, so you really have to see that it's abnormal movement. The patient cannot control that. So this young girl has difficulty holding the pen when writing. It's like choric, dancing movements. And you can also have some kind of stereotypy, so it's a repetitive movement, and also it's very uncontrolled movement. And a very complicating thing is that this kind of different abnormal movement can be combined, and that's the role of the neurologist to analyze and to see where to look in the brain to make the diagnosis. I talked previously about psychiatric symptoms, so we are working on these symptoms because it's very, very frequent. We know that 20% of patients had seen a psychiatrist prior to the diagnosis of Wilson's disease, and the main symptoms are depression, bipolar disorder, mania, anxiety, or incongruous behavior, or even psychosis. And it's very complicated because when patients started the disease by psychiatric disturbances, the delay to the diagnosis is very, very long, usually more than 2 years, because it's not at all specific of Wilson's disease. This kind of psychiatric symptoms can be encountered in different situations, so it's not at all specific of Wilson's. That's the reason why it's so difficult to think of Wilson's disease in this case. Below the age of 18, the neurological symptoms are rare. In our cohorts, it was 10%. And the main symptoms in children are usually abnormal behavior like irritability, anxiety, apathy, withdrawing or hyperactivity at school. And then patient may have difficulty with writing, dysathria, gait disorder, or tremor. So this is for young people before the age of 18. This is the case of Ines, who started the disease at 11 years old with painful legs. And then 7 months after, she started to have difficulty with writing, and especially because she has some micrographia. She could not write properly, and we saw at the school that she had difficulty. And 2 months after, she started to have dysarthria, hypersalivation and contraction of the mouth, and her hand started to be rigid, and she had difficulty to use her hand. You can see the slowness of movement as well. So the first symptom here was painful legs for months, so it can be very tricky. And so we have young form, but we also have tardy form of Wilson's disease. And thanks to the registry, we look at the patient who started their disease after the age of 40 years old. And we find that 8% of patients develop their first symptoms after 40 years old. And among these 8%, the majority of patients had neurological symptoms. That's as a neurologist, we have to think always, we have to think at this diagnosis, even on patients after 40 years old, because it exists. That's the main message that I try to communicate in Congress, in Neurological Congress, always think of Wilson's disease. And in these cases, patients started for example, Gerard started his disease at the age of 48 years old, and concerning his liver, he has advanced cirrhosis associated. So we have the clinics to look at, to think of the brain involvement, and then hopefully we have the brain MRIs. And the brain MRIs is very important. You saw it in the previous presentation. Now the guidelines recommend to propose a brain MRIs in all new Wilson's disease patients, and of course even if they have neurological symptoms. So the brain MRIs anomalies are very classical. So the white stuff you can see deeply in the brain is the copper deposit. It's very symmetrical, and the brain MRI is almost abnormal, always abnormal in patients with symptoms, neurological symptoms. The very tricky thing is that patients with hepatic symptoms only can have some slight abnormalities of the brain MRIs. That's the reason why we recommend to do a brain MRIs in every patient. So the lesion can be very typical, but we have also very atypical lesions. I'm not going to go deeply in it, but just to tell you that it's not so straightforward. Sometimes the lesions are not very typical. So that's the reason why we have to talk about our patient. We have some monthly brainstorming about Wilson's disease patient cases, because sometimes we find some very strange anomalies in the brain, but we learn a lot from the patient, also to improve our way of dealing with the disease. Apart from the brain MRI, we look at the eyes, because the eyes is the continuation of the brain, and for the neurologist, so it's very important to look at it. And we have very typical feature in the eyes. We have this Kaiser-Fleischer ring, which is the copper deposit in a thin layer of the back of the cornea. So it could be green, gray, it's very different, but it's always bilateral. And when you treat the patient, this Kaiser-Fleischer ring progressively disappears. When the patient does not take the treatment properly, we can see the Kaiser-Fleischer ring that re-increase. So it's a very nice marker to see how is the adherence to treatment. So it's always present in all neurological patients, and the Kaiser-Fleischer ring is also present in almost 50% of the hepatic patients. So it's a reflect of the diffusion of the copper outside the liver. We have a lot of techniques to see this Kaiser-Fleischer ring. Now we have color anterior segment photograph, so you can see it very nicely. And if it's a very thin copper deposit, we have new technique like this optical coherence tomography. And so I don't know if you see properly, but it's this very tiny white line in the cornea. So, you know, ophthalmologists now have a lot of techniques to see very, very tiny case of leisure ring. We have also, maybe you have heard of sunflower cataracts. It's rarer. It's like a sunflower cataract. It's due to the deposit of copper in the anterior capsula. It does not interfere with vision, and also it disappears with treatment. What about blood and urine testing in a neurological patient? Of course, we look at the biology characteristic, and usually patients have cirrhosis. Neurological patients, 50% of the patients have a cirrhosis. So we have in the biology the sign of the cirrhosis, and one sign is the low platelet, so it's the slight thrombopenia. Of course, we look at the copper, so it's like in liver disease. We have the typical low ceruloplasmin, low total serum copper, and high urinary copper excretion. And we use exchangeable copper. So you've heard of it in the guidelines. The exchangeable copper is the toxic copper that circulates in the bloodstream. And now we can dose it directly. And we know that when this exchangeable copper, so this free toxic copper, is high, it can sign an extrahepatic involvement. So it can sign that the copper went outside the liver, and especially in the eyes and the brain. So this direct dosage of the free copper, the toxic copper, called exchangeable copper, when we look at the relative exchangeable copper, when it's up it's above 14%, it's a very good biomarker for the diagnosis. So we use it very constantly. It helps us to differentiate healthy people from normal carriers. And even in Wilson, the REC differentiates Wilsonian liver disease from non-Wilsonian hepatic disease, so it's very important. And concerning the brain, as I told you, it's a exchangeable copper, this direct dosage. It's a marker of the severity of the brain impairment and the eyes copper overload. The important thing is that exchangeable copper is very rapid. We have the result in a few days. So it's accelerate the diagnosis and the evaluation of the copper overload. So as my colleague told you, now it's the REC, the relative exchangeable copper, belongs to belongs to all the tests to make the diagnosis of Wilson's disease. So the question is, how is the liver in patients with neurological Wilson's disease? So as I told you, half of the patients have a severe liver involvement, especially cirrhosis. And usually it's a silent cirrhosis, very compensated cirrhosis. But we have to, of course, as a neurologist, I really have to send my patient to a hepatologist because they have to be checked for the liver very regularly. Some patients may have asymptomatic anomalies, like a slight thrombopenia, and all patients may have steatosis at least in the ultrasound liver. So, how do we treat patients with neurological symptoms? So it's like for the liver, we have chelators, okay? So we use chelators, but what we know is that chelator for the brain is not as effective as for the liver. So it works. You can see that it improves neurological symptoms between 55 to 67%, so it works, but it's not a full improvement. If you compare with the liver, for example, the penicillamine improved the hepatic cases in 90%. In the brain, it's improved in 67%. So it's not as good, but it works. And there is another study that compares zinc salt and chelators for the brains, and it concluded that finally zinc and chelator are as effective for the brain. So it's I don't know how neurological patients are treated in Spain, but usually we can use chelators or zinc. And these are the recommendations from the guidelines. For brain involvement, you can use chelators or brain. If you use chelators, the very, very important thing is to start slow and go slow, because we have a risk of early paradoxical involvement. Oof. So I have 2 minutes? 1 minute, oh. So just think of symptomatic treatment as well. So treatment of the disease, but also treatment of the symptoms. We have a lot of treatment for the symptoms. And for neurological symptoms, for psychiatry symptoms, there's a list of the treatment we use. And the response is quite good, as I told you. So this is an example of a patient with a severe dystonia at diagnosis. And then she in 3 years, the dystonia decreased a lot. She couldn't speak, and then she could speak 3 years after. And she started a job 3 years after the beginning. Sorry, but the video seems... Ah, yeah, she's working later. She had a serious axial dystonia that disappeared. So still she has some symptoms, but the recovery was quite good. For tremor is a good example of a very, very nice recovery. This lady had a very, very important tremor at diagnosis, and in 2 years the tremor completely disappeared. At the beginning she couldn't walk, and 2 years after she could walk properly. So the effect on tremor is very, very high, more than in dystonia. But so Kaiser-Fleischer ring is going to disappear progressively. The brain MRI is progressively normalizing in the majority of patients, but some patients may have persistent anomalies in the brain with maybe necrosis due to the copper accumulation. Our problem is the early paradoxical neurological worsening that can appear in the beginning of the treatment. And I just want to I'm so sorry, I have 2 minutes to talk. Just a thing for this early paradoxical worsening. At the beginning of the treatment, 20% of the patient may have a worsening of the symptoms despite a very progressive increase of the dose. And so it's a very frightening, and sometimes we have to find another solution. One solution may be a liver transplantation. So now in the guidelines, we are thinking of, in certain patients, case-to-case patients, propose a liver transplantation for those patients. And that's the case of Inez that I showed you the initial presentation. She had a severe dystonia at the beginning, so she was transplanted. And now we are 10 years after the transplantation, and she's really transformed by the liver transplantation. So it's a case-to-case decision, but in some time it can very change the life of the patients. So just a word to conclude. We have to think of the brain in every patient. It's very important to, at the diagnosis, to see how it is and to follow those patients. If the treatment is not good, if the treatment is stopped, neurological symptoms can appear. So we have to communicate between liver specialist and brain specialist. And we have a lot of challenge with neurological symptoms, but it will be a next presentation for that. Thank you so much. I will thank the patient also. And that's it.